Water for recess, please.
Can you open your mouth? Have you lost any teeth?
Simon, can you see a light?
There are literally dozens of separate fractures. The worry is he'll lose the actual left eye itself.
Shit. Is that on his head?
It's just missed.
She stays still.
Anyone free to come and help with the drain? My main concern at the moment is the lung is collapsed on the left-hand side, which can result in an immediate cardiac arrest.
Where's your pain at the moment? High pressure detector check.
Blood pressure has dropped.
Sorry.
Don't leave.
Sorry.
But you're bleeding inside your tummy very badly. We have to stop that bleeding. If you don't do it, you probably will die.
4 units of cross-match blood run their way up now. I want the out now. You can't go out! Who needs an FO3?
Check.
Hello, resource. Yeah, go on. Yeah. Okay. How long will they be? And it's a head injury. Thanks, bye. Got a head injury. Got 2 standbys now.
ETA 25.
25 past.
So now we're on standby for trauma, which is a youngish man, 30-something, who's been hit in the face by a large chunk of metal. So I've got all sorts of worries now about brain injury and facial injuries and eye injuries, and is there bleeding in the brain, and what level of consciousness are we going to be dealing with? We'll just have to see what he's like when he gets here.
This trolley here when you're going into fall.
Can you put him in a cubicle, please?
You might put the bed up. Excuse me. Sorry, excuse me. Can you put the bed up a bit more, please? One move, we'll just all shuffle them, that's okay. So, okay, ready, steady, move. This is Simon. He's 37 years of age. He's been working in an industrial estate with a metal fabrication under hydraulic pressure. Essentially, a sheet of metal, about 1/4 of a ton, has come out and shot and hit him in the face. Most notably to the left side of his face, possible skull fractures with some possible arterial bleeds in there. Initially, he was quite responsive, GCS 15, gradually deteriorating, okay? Because of the blood in his airway, he's unable to tolerate putting his head backwards, so we're trying to use mills to mitigate that.
Simon, I'm just going to take your boots off, all right?
Welcome.
Simon? Yeah? Do you know where you are?
So we're just putting your clothes on so we can get to you and get the line and you're all right.
Can you open your mouth?
Yeah.
Okay, have you lost any teeth? Can you feel that?
Sharp scratch coming off.
There's a very big blood supply to the face. You can bleed a lot when you injure the face as badly as he has. Bleeding from facial fractures can actually be bad enough to kill you.
Finding anything?
He's got a wound extending from his left eyebrow up to his upper lip on the left side as well.
Single injury?
Single injury.
Single
to
impact?
the face.
Right,
Single.
okay. What was his issue in terms of lying flat? What does he feel is the problem?
So he feels that the blood would go at the back of his throat.
Right.
Feels like he's started getting a haematoma on the back of his head now.
So what hit him?
And it's hit him on we think it's hit him on this jagged edge here. It's about that long, I'd say, that thick.
So it's going to weigh 100 kilos probably, isn't it?
It was a heavy piece.
Simon,
Yeah.
we're pretty sure you've probably broken some bones in your face underneath all these cuts.
Right.
We're going to speak with the radiologists about getting a scan done. And then we'll have to come round with you to scan and see what happens when we lay you flat. Are you understanding me?
Yeah.
Yeah? Okay. I'll go speak to radiology.
Anthony, we can go. Do you want to go with Simon first?
Please.
Yeah, okay.
Yeah. There's a fairly high suspicion he's broken multiple things in his face. There's a worry that he's injured particularly the left eye. And there's always a bit of a worry of when you have such extensive facial injuries, whether there's something going on inside the brain. So scanning him is going to be maybe a tiny bit problematic in terms of getting him to lie flat because of bleeding. Simon, you're in the scanner. All right. So what we're going to have to do is lie you flat. Do you understand me? Simon?
Yeah.
Okay. You can hang on like that for about 2.5 minutes. That's about all we need, all right? Just lie nice and still for us. It's a frontal contusion.
Is there any one side that he got hit, or was it
Left side's slightly worse than right.
Looks like the eye.
orbit, and this eye is not in place? Is it lodged off or something?
I would have expected it to have destroyed the left globe. He's going to have collapsed the left side of his face, maxillary, orbit, yeah.
So lodged.
And taken the globe with it, presumably. Yeah, okay. So he's going to lose his left eye. Done?
Yeah.
Can we get him up? The scans have showed he's got an injury to the actual globe of the left eye. The worry is he'll lose the sight in the eye, or maybe even the actual left eye itself. He's terribly unlucky in that he's had this happen to him, and I don't know whether the eye is going to be salvageable. He's got a bunch of soft tissue wounds that are going to need sorting out, that the maxillofacial surgeons are going to sort out at the same time as the ophthalmologists are looking at the eye. There are literally dozens of separate fractures, and it's just in so many pieces that I'm not sure where they're going to start. Simon, how you doing? Facial surgeon's here. So we're going to probably start taking down some of these bandages to have a wee look at what's going on. Yeah. All right?
Yeah.
The first look at the scans show us that you've broken a lot of the bones in the left-hand side of your face. The other thing we're worried about on the scan is what's happened to your left eye.
Simon, I'm just sitting here. I'm one of the facial surgeons, okay? I'm just going to have a quick look, yeah? Are you in much pain? No, okay. Can you speak to me at all? Okay.
Do you want me to put the bandages?
Yeah, okay.
Ophthalmology coming in?
Yeah. Would you track him down 1.2 of augmentin, please, and we'll give him a shot of that while we're at it.
Simon, as you probably know that you've had a nasty injury. Okay, we're just waiting for a couple of people now to make an assessment. Just need to check your eye out, okay? It's very likely we need to take you to theatre today, all right?
Yes, I know. Yes, it's going to be a proper life-changing injury, that is, isn't it, for this guy?
Has anybody informed his wife how kind of
I don't know yet. She's on her way. That'll be my job when she gets here.
We'll start making plans to take it.
Yeah. Well, shouldn't take long, okay?
Okay, thanks.
Right. Front part, it's all blood there. I can't see in the anterior chamber.
So we just need to make a plan of what we're going to do. We need to close his soft tissue. Yeah. Okay, that's priority. Yeah. Okay. We need to do that today. Yeah. Right, yeah. Good plan for him.
The plan will be that he's going to theatre urgently. That will be for the first of more than one surgery, I suspect. And I think that'll be a long and involved process.
Shall I just secure that one in your arm, my love?
I need somebody down here now to make a decision on this gentleman. Push away through to the X-ray, please.
4 units of bread and FFP.
Hello, Amy Stoke. Yeah, 42. Yeah. Okay, thanks. Bye. Bye. Paul Di Adamson. Chopper. Di, so there's a trauma coming at 14:20.
Okay, what is it?
42-year-old male car. He's been trapped between a car and a wall.
Right.
They're flying him in. He's got a left arm injury, quite significant. Previous pneumothorax to the left side, GCS 15.
Okay, good, thanks.
Bare below the elbows to everybody. If we do end up intubating, we all need full kit. You can bleed out from a limb. You know, they're concerned that he's bled into his chest, and your chest can take almost all of your blood volume. Okay, he's here. And then just to sort of round it off and make it worse, it's nice and cold today, and he's been trapped for a considerable period of time.
Straight line from the end, do you want to go?
This is Gavin. So Gavin's been entrapped between a car which has rolled onto his arm in that position. He's been entrapped for approximately 45 minutes by his arm. Injury sustained, left-sided, significant open wound to axilla and upper limb with neurovascular compromise. Distally, chest wall tenderness left side, reduced air entry. Strong peripheral pulse on the right side, absent peripheral pulse on the left side initially. It's now weak.
Okay, guys, let's crack on. Thank you.
I'm just going to start by getting you off this board, all right?
So it does sound like the arm injury is pretty significant. He lost his pulse completely when he was out there.
So there's some superficial scraping to that left side.
That's the chest.
Yeah, reduced air entry on the left side.
On the left, okay. Gavin, how did you actually do this? Were you driving the car or?
The car started rolling, so I sort of went like that.
Yeah, and didn't get in time?
No.
Okay. So we're going to need to get some closer imaging of this arm. The worry with the arm is that the pulse isn't as good as it should be. No. And the worry is that there may be some damage to one of the blood vessels in there or some of the nerves, okay? So what we're going to do is get the bone doctors to come down, but we just need to make sure there's nothing else at all that you've injured, okay? A little bit worried about this side of your chest, okay, but we'll get a scan straight away and have a look at that. Do you want to see the images then? So it goes right up into the axilla there, so he had no pulse, then a feeble pulse, and then had shit. Is that on his head?
Just missed. System I can upload them onto iPortal.
Okay, so I'll leave you orthopaedic people with that. A bit worried, he's got quite a lot of air in the soft tissue on the left-hand side. If he's got a wound that's kind of going up in here into his armpit, then it could just be coming from there, but obviously the worry is that's the sign of a pneumothorax, so the sign of the lung collapsing that side. If it collapses fully down, it can push the heart over to the other side of the chest, which can result in an immediate cardiac arrest. So I want to get him scanned and rule that out first. Okay. It's always about finding the life-threatening injuries. We just need to make sure we're not missing anything. He's quite a poorly man. He was pulseless at scene with that left arm, but then he got a feeble pulse back, but he had power only 2 out of 5. I guess the biggest thing I want to know is whether there's a pneumothorax there.
Injection starting now.
Breathe normally.
So extensive left-sided surgical emphysema, as you can see. Left-sided pneumothorax. There is some perihepatic free fluid, no laceration. Yeah. I can't.
So did you say free fluid in the abdomen then?
Subtle, right, perihepatic. But it's difficult to tell for sure here.
Okay. I think we're getting back and get this pneumothorax. Get the drain.
Yeah, he can come off first.
Yeah, let's get him off then. The scan showing that he has got a pneumothorax, so the lung is partially collapsed on the left-hand side, which is what I was a bit worried about because there's so much gas around in the tissue. Anyone free to come and help with the drain? We have to decompress it immediately or it will kill the patient. Gavin?
What?
because of the pressure on your chest, it's caused the lung to go down.
Yeah.
Okay. We need to just pop a little drain in that side just to
Yeah.
help the lung come back up.
Yeah.
Okay. Bit of pushing, darling. All right, well done. Okay. Doing really well. Chest drain will drain the air out of the thoracic cavity because it's pushing the lung down. So that will mean that his lung will re-expand, allowing him to breathe normally. You all right?
Yeah.
Right then, are you ready to connect this up? Well done.
Thanks.
How's the breathing feeling?
Yeah.
Okay. So I've just put a chest drain in for him. Now, the main concern at the moment is why the power in his arm is so reduced. You have a big plexus, so a big mat of nerves that run down from the neck. It's called the brachial plexus, and they run down into the arm and all the main nerves of the arm. And if you give that a really good stretch, you can kind of rip and tear them. And that has really significant impact on function in a limb after injury. So it may be that he needs quite significant repair, or that he may go on to have significant sort of loss of power and function on that side of his body. How's your pain now? Out of 10?
No, all right, it just feels numb.
Feels numb? Okay, so I'm just going to give you a little switch of this because I know that my orthopaedic colleagues are going to have a little root around. I'm going to go and see what the results of your scan were. And then the bone doctors are going to come in because they want to have a look at this arm.
Yeah.
Preliminary CT report back, and that shows us a little bit more than we knew about. So there is multiple ribs. The shoulder blade has gone that side, the clavicle, the bone here has gone that side, but also there's some fractures in the spine. Also, the dye that goes round on that scan has shown that the artery going into the arm isn't filling properly. If we can't get the blood supply down there and working, then he'll lose the arm. Vascular surgeons are here, they're having a look at the scan, and then they will go in and have another look at him and then make a plan from there as to what they're going to do.
I've had a very quick look at your scans. Based on what we've looked, it looks like you've got a fracture through the top of your arm. Okay. Potentially some ribs as well, and also your shoulder blade as well. Now, what we need to do is just check all the nerves and the blood vessels in the hand are working. All right, perfect.
Every second that that limb is starved of oxygen may mean an alteration long-term in the function of that limb or the loss of the limb ultimately.
It's very faint, but we can hear it, so that's reassuring. You will need a trip to theatre. We need to give it a bit of a wash and clean and make sure that there's nothing dirty inside there. Okay? And we'll take things from there. But again, we need to, firstly, before anything, we need to make sure that the blood supply is okay to your hand. Okay?
So I think the most important thing is not the actual open fractures. The first thing is getting the blood supply correct into that arm, or it will die. So we need to get that sorted out. Then after that, the spinal fractures. And then after that, just looking after him to get over all of these other major injuries that he has.
There you go. Ultrasound. There's no cannula because he pulled it.
What, this one over this side?
It's not flushing.
He's got a dissection right from the arch. He probably has got a small pericardial effusion with it, and he's got no flow down his right iliac vessel.
Simon, what I want you to do is I just want you to open your mouth for me, okay? right? I'm just going to really suck and just to make sure there's nothing there. Trying to intubate is always a risky procedure, and that is why we've got all the backup here. The other issue is the severe bleeding that you can get. You know, we are ready to go if there's any problems in trying to secure his airway.
And you know when you're ready for the...
The injury that he sustained is predominantly a craniofacial injury, which involves both soft tissue, his left eye, significant injuries to his skull base, orbit, nasal bones, and his upper jaw. We're going to carry out an evaluation of his left eye to see whether this has been ruptured or not, and try to obtain a soft tissue closure. The first part of the injury is actually to try to do this urgently as possible. I think so the most important part is going to be the eye globe itself. If he has got a rupture, this needs to be repaired pretty quickly.
I think that's it.
The lens is in place.
Is it?
Yeah. It's just the retina is all over the place. It was all over here. From 3 to 9. Almost 180. Gosh.
Okay.
Thank you.
Done. Thank you.
Okay.
So we're going to start the exploration now. So they've had a look at the eye itself, and they found that it actually had a rupture of 180 degrees around the globe. So they've repaired that. So only time will now say whether he will regain all his vision in that eye. Okay, so can I have I need a 4 or so to start off with, yeah? Can I have the eyelid retractors, please, yeah? With major mid-face fractures, one of the biggest issues is the loss of airway, and that is because of the severe intrusion of the mid-face into the posterior pharyngeal wall. This can be extremely life-threatening because the risk of bleeding is predominantly due through the mid-face. So we want to try to stabilize the bone to prevent any further bleeding and also airway compromise in the future.
Posterior table intact.
No, it's broken. I'm just going to lose this small fragment there. So I'm just going to leave the big pieces as they are. Yeah.
Yeah.
There's nothing there. There's no bone there.
Jesus Christ.
Yeah, there's absolutely nothing. There's nothing here, guys. There's nothing here. So one of the big problems we have now is that the maxilla is actually into multiple fragments, and it's actually so loose, right, that the only way to trying to stabilize this is trying to fix it just temporarily. We want to find a bone that has got adequate volume and strength that you can plate a mobile fracture onto it to prevent it getting loose or moving. So the thing is that if it's so mobile, it's such an airway risk, isn't it? Now, in Simon's case, his whole of his upper jaw has been pushed backwards. That will actually occlude the airway. So now, I'm just going to put a temporary plate there, yeah? Okay, another plate, please, yeah? He has got some stable bone, which is part of the cheekbone, and we will stabilize a part of the upper jaw onto that area.
That's free floating, that.
Yeah, it is. This is free floating, yeah? Okay, so if I fix this plate to the cheekbone here, okay, I'll get some stability. Just need to span a plate across here, just to hold it in the right place, and we can just close the soft tissue here. Okay, can I have the screws, please, ready?
Yeah.
Okay, that's stabilized, please, yeah? The most important thing is just to stabilize this, yeah? So if we close this, yeah? Then we'll just have to come back next week, yeah? Yeah. He's going to ITU, yeah?
Yes.
At least it's not floating in the air, is it? Yeah. Yeah. This is purely temporary, yeah? Yeah, so basically we've just stabilized it. Yes, it's not moving around now, yeah?
Stabilized.
It's stabilized, yeah. In terms of the orbital injury, he has had a globe rupture. He's got very significant lacerations, and that's been closed primarily. His maxilla was in multiple fragments. We've stabilized that by just putting simple plates across it so that it doesn't move significantly, and also that will prevent any further bleeding. The patient is now going to go to ITU. He's going to remain there for close clinical observation. During this period, we want to see how he neurologically progresses, and then once he's stabilized, we will then do his definitive surgery next week.
That was a trauma desk.
I mean, come on. I've got 2 traumas, a kid, and peri-arrest that's gone with the other doctor.
Hello, resource. Okay.
Oh, blimey, okay.
Is there any suspected injuries on his head or face? Perfect. We will see you shortly. Thanks very much. Thanks. Bye.
Trauma call.
What have we got?
So it's RTC. Driver's been driving around 55 miles per hour and crashed into 2 cars head on. He's complaining of pain in his right flank below ribs, and they don't know if he's had a loss of consciousness. He's a 73-year-old male.
If he's been trapped a little while, so he's probably a Cat 3 for now, and then we'll see how we go from there. We need a trolley. We'll have that trolley. Let's have that trolley. An elderly-ish gentleman who's had a road traffic accident. Apparently there's been a head-on collision. He's awake and talking, but he is 70-odd, so they will sometimes mask injuries that you don't know, and they'll suffer injuries that younger, fitter people will not. So you have a higher index of suspicion when you're dealing with a slightly older category of trauma patients. So we'll see. Okay. Oh, hello. If you head down the left-hand side. Hello, sir.
So we've got Mr. Anthony, 73. RTC, estimated speed is going to be somewhere around about 100 to 120 combined. Doctor survey at the moment is he's complaining of right-sided abdo pain going round to his back. He wants to keep moving it, but we've kept him isolated, and because of the injury, we've also kept him immobilised with the neck there. He's been relatively stable up to the point when we arrived, where his blood pressure did drip to about 90, over 60 at that point in time.
All right. Okay, we'll give him some TXA as soon as possible. What was the last blood pressure?
Our last blood pressure was 88 over 60.
Okay.
Yeah. Take us a few deep breaths. Let me have a listen to your lungs. And again. And again, please. Excellent. Any pain when I squeeze your ribs?
No.
Good. Any pain if I press on your ribs here?
Just a little bit. I just felt that there.
You up here a bit?
Yeah.
Okay. Can I have a little feel of your tummy? Just let me know if anything's sore. Bit sore there?
Yeah.
Okay.
Oh.
Is that the worst bit?
Yeah.
Yeah.
That's one.
This.
Oh, I do there. Oh.
That last tap was actually over the lower ribs, maybe 10, 11, 12.
Okay, so possibly liver injury.
So he's tender right upper quadrant, he's tender right lower ribs.
So I'm thinking he's got some chest, abdomen injury. Could be head injury as well.
Do you want any portable x-rays, or are you going to stand x-ray down? We're going to take an x-ray of your chest and probably an x-ray of your pelvis as well. His pulse rate's not picking up superbly well, so if we can at least have a pulse rate from the ECG leads, that'll be helpful. So, that rib and that rib, and maybe that rib. I think there's a couple of ribs gone, and that's where some of his pain's coming from. What do you do for a living?
I'm retired.
You're retired?
Yeah.
Lucky bugger. What did you used to do?
I worked at the pit for 25 years.
The pits?
Yeah.
See, there's a tough way of making an easy living, eh?
Yeah.
My granddad was a miner.
Oh.
Yeah.
Anthony, are you in any pain?
This one down here. That one.
How bad is it on a scale of 1 to 10?
Oh, 7.
Okay.
Am I okay?
Are you okay? Well, you're here and you're awake and you're talking. So you might have some stuff going on, but we're going to do some scans and trying to find that out for you.
Okay.
All right.
Oh. Yeah.
We're going to have to get some of your kit off now and get you in one of our gowns ready for scan. All right. Are you happy to take him to CT then?
Yeah.
Okay. And the worry is that, has he got an injury to the stuff that sits underneath the ribs, whether it be lung or whether it be liver? Everybody feels pain differently, everybody's brain works differently. So it is possible, yes, that he downplays his pain just because of what the sort of person he is. We'll see how he gets on and we'll see if his scans come back as okay. We'll give him a bit of this.
Yeah, how much do you want to
just...
Anthony?
So yeah.
His blood pressure has dropped to 55.
In here.
Oh,
All over your tummy.
You speak to the surgical reg and ask him to attend for... Anthony, your blood pressure's gone a bit funny. We're worried there's a bit of bleeding inside your tummy. You know where you were sore before?
Yeah.
We think you're probably sore because you've actually injured something. So what we're going to do is give you a bit of blood back.
Oh, wow.
Reach your nose.
Sorry.
Yeah, you're right.
Patient's bleeding to death.
The pain in your back, it's all this bleeding in your tummy. High pressure detected, check patient line or blockage.
Can they release type specific now or will there be a delay? You clearly have a finite amount of blood to spare. People can bleed to death in seconds in certain cases, so it's vitally important to try and identify where you think you're bleeding, how to turn it off.
Do you want another O neg or just wait?
I'll give him the 2O neg now. Yes, please. Yeah.
Blood pressure's now 44.
In very unstable patients, almost everything becomes time critical. You have a finite amount of time to actually solve these problems before a patient gets into real trouble.
We're taking you to theatres, okay? We're gonna have a cut in the middle of your tummy under a general anaesthetic, okay? And we're gonna have a look inside. But you're bleeding inside your tummy very badly. We have to stop that bleeding. It's a life-saving resuscitative operation. If you don't do it, you probably will die. Anthony, you there? So you happy for us to proceed?
Yeah.
Thank you.
And ask me to
Where's it hurting? All over you.
When dealing with really ill people, experience gives you a guide to how you feel they're going to go. And there are times you are more hopeful than others, for sure, about somebody's prospects. We're here to try and give people their loved ones back. And we know there are certain things we cannot fix and there are certain things we can. So we do all the stuff we can because you'd want somebody to do the same for your loved one if they were in an accident. And you have to never lose sight of that.
Trips then goes straight down like that.
trauma to the head that probably has led to the apnea and the arrest.
Okay, we're in here. We've got blood.
In his bath, so he's at respiratory arrest. 10 minutes. All right, I'll let him know. Thank you. Bye. Unresponsive male found in the bath. GCS of 3.
So we've got an elderly gentleman, 86, is fallen in the bath. He's had a respiratory arrest, so he stopped breathing. And currently he's got a very low conscious level. It's only 4 out of 15, the lowest being 3. Doesn't sound like he's very well. This way, please. Trauma alert. What's his name?
Guys, we called John William.
Initially respiratory at about 40, saturations of 70% on air, foaming at the mouth. So we've got him out the bath as quick as we could.
John, can you hear me? Yeah. You in any pain at all? Yeah? Where's the pain? So if he has stopped breathing, that's going to put him at significant risk of further complications within the first 24, 48 hours.
It's all right, you're okay.
At the moment, worried whether he's had a potential stroke or some sort of neurological event. Worried about potential spine. Chest is a little bit bubbly. He's got poor saturations. We're going to give you some painkillers, John, all right? You just concentrate on your breathing, all right? Keep him up for CT. So we'll titrate his oxygen to stats of 88%. Can we give him a stat dose of Comaxiclav as well? He's not very well, that's for sure. He's really got problems breathing at the moment. We're worried that he's potentially sustained some injuries, whether that's sort of internal, like organ damage to liver, spleen, or whether he's got a spinal injury, as well as the fact he's quite critically unwell just at this time. So we know he's COPD. He's got a low blood pressure. His temperature is high, so potentially he's been brewing an infection from sepsis or something else. Right, CT's ready, so if we make... You just stay nice and still and nice and relaxed for us, okay? Just gonna get a scan of you, see if you've broken anything. All right. So we're not sure whether he's had a medical event causing him to collapse or whether he's fallen and had trauma or...
William, just try and stay still for me.
No pneumothorax. There's multiple rib fractures. Do you see that?
Oh yeah, oh gotcha.
That's one of the main things. Multiple.
Definitely ventilation's a problem for him. But multiple right-sided rib fractures.
Bilateral.
Bilateral. So we'll just take him back to recess and come on work and stuff. Cheers, thank you.
All done.
He's sustained an acute chest injury, so he's got multiple rib fractures on the left side. Also looks like he's got some bleeding around those fractures. He's quite unwell, so there's still a long way for him to go. John, do you want some more painkillers? Yeah. Okay, we'll get you some more. I'm just about to go chat to the family. Hopefully they can come in and have a chat to him and give a bit of moral support for him.
We're going to see in a bit. See how your results are.
He's my brother-in-law. We've always been close. His cleaner phoned and she said they've had to get into John and he's foul in the bath. He's going in the ambulance and he's not in a good way. So it's a bit of a shock, really.
Yeah.
I've been worried about him for a while, really. He's had a few falls. It is. It's terrible to see him struggling to breathe, isn't it? You know, but he's in the right place, and I'm sure they'll do everything they can for him.
Don't worry.
He's very good, really. He's a good person. Good person. He'll do anybody a good turn. He really would. He's worked hard all his life, really, and then he got knocked off his pedal bike, and he broke his back, and he's never been the same since, really. He was so slim and energetic. That's life.
He'll be admitted to hospital. Part of where he goes will depend on his results. He's got bilateral rib fractures with his COPD, which obviously is affecting his breathing. Hopefully we can stabilise him a bit fairly shortly. But obviously, given his age, next day or so is going to be really critical for him.
Oh, damn.
She's been on the floor 18 hours. BP 74/70. She's on warfarin. No evidence of headache or of any injuries, but masses of hematemesis on scene.
Oh, it's Mel again. Got another one for you.